Hey, so welcome back everyone, or if you are just joining us, welcome to the Penn CFAR Implementation Science Symposium. My name is Stephen Meanley, and I am an assistant professor and HIV and community health researcher at University of Pennsylvania School of Nursing. And so I get the pleasure to introduce the second half of our panel of HIV implementation experts. So our first talk today is with Dr. Toorjo Ghose. Dr. Ghose is an associate professor at Penn School of Social Policy and Practice. Dr. Ghose's work focuses on structural and community-based interventions with people living with or are at high risk of HIV infection or confronted with multiple social barriers. Specifically, Dr. Ghose works with communities that are at high risk of incarceration, homelessness, substance use, and mental illness. Dr. Ghose, the floor is all yours.
Thank you, Dr. Mainley. Thanks for this amazing opportunity to present our work on, adherence, HIV, ARV adherence in New York City. I'm going to just share the screen and hope this works. So this is we actually had kind of a mandate come down from the Department of Health and Mental Hygiene at DOHMH in New York City, where we were asked to really look at that really difficult 15% that I think Dr. Coleman started our sessions with this morning, where, we really could not seem to be getting adherence, our 90% adherence for 90% folks in a very entrenched group who had multiple social barriers: substance use, homelessness, mental illness. So I worked in New York with Housing Works, which is possibly the largest HIV service organization right now in the country. Provides housing mostly, but also provides primary care and ARV treatment, psychosocial care, and usually working very closely with communities that are the most vulnerable in New York. So the LGBTQ community, homeless, substance users, formerly incarcerated, and a community with a high prevalence of mental illness. We called it the Undetectables Project because our mandate literally was to get to undetectable for this community. We started out with perhaps a 50% adherence rate in this community at any given point in time, compared to about 85% in the rest of New York at this point. So when Housing Works came to us and we came to Housing Works, we've been collaborating on a number of levels for a number of years. We kind of collaboratively designed a 5-tiered program based on evidence-based interventions around the world with very, very hard to reach communities. And it was a 5-tiered process. The first tier, believe it or not, was the use of graphic novels. I'm going to just spell this out as we go along, so I won't spend too much time on this. The second tier, for those who for whom the first tier worked and got them into treatment, was developing HIV teams around viral loads, really focused on viral loads. And this was an interdisciplinary team that consisted of nurses and doctors and social workers and housing folks. Tier 3, for those who remained detectable, these folks were triaged into a group where they were provided incentives for being undetectable. I'll talk a little bit about that. And tier 4, for those who still remained undetectable, were triaged now into CBT and MI, that's cognitive behavioral therapy and motivational interviewing groups around adherence. And then for those who continue to remain non-adherent, we did directly observed therapy. So the first level of this was the graphic novel. And I'm going to be adventurous and just give you hopefully a hint of what this looks like. I really hope this works. So let's see. There we go. So this is a site that I would highly encourage you to visit. It's the Undetectable site, and it's for New York, but it has been replicated by other jurisdictions. And we literally developed an entire comic book line with storylines of folks who are superheroes in this fight to reach adherence, and with supervillains present. If you have the time, do go on. It took us a long while to work with artists to develop this line. This was basically to get people who were non-adherent, who had never been engaged in care, into care in the first place. So we had the relentless advocate. We had folks like, the gender warrior. We had the harm reducer, and we had villains too come up. We had denial as a super villain, and we had fear. So if you go onto the website, it's pretty amusing, and quite frankly, coming from from a perspective of a social worker, I was a little bit skeptical about this, but the artists in our group were absolutely adamant that this would change the community orientation to being in care, and it totally, absolutely did. So I'm going to now try to come out. Tier 2 was developing these HIV care teams. You've heard a lot about this from others also. We had monthly training of all these folks, nurses, doctors, etc., in the uptake of this kind of care. We from Penn, we would go out and we'd actually spend an entire day once a month talking about primary care, talking about therapeutic processes, talking about even case management conducted with motivational interviewing and CBT processes. We had apart from these trainings, we had monthly quality review meetings where we actually looked at viral loads by person to see who was actually adherent and who wasn't. And then the care team would just discuss all the psychosocial processes and barriers that may be at play with a particular person. Weekly consultations between the Penn team and the Housing Works team. Tier 3, as I told you, was one where we actually provided $100 for everybody who was undetectable. And Tier 4 was for those who still continue to remain detectable. We had a model that has been developed in a center I run here at Penn for folks coming out of prison called the CHATS model. It's a very, very deceptively simple modality which uses some basic processes of CBT to talk about challenges to being adherent. And the group becomes really involved in supporting each other through a psychodynamic process, and checks in every week with each other to make sure that folks are adherent. And then we had DOT, we had text reminders, we had in-session pill handouts, etc. for those who continue to remain detectable. We studied this, of course. That was, we were actually doing a longitudinal study of this, a mixed method study. There were 482 participants enrolled in the intervention. We could not randomize because of the particular, setting here in the community. It wasn't ethical to randomize. So what we did was we conducted a pretty, fancy form of a pre-post design where we followed folks for 2 years prior to being engaged. We had data for 2 years. So we set a really, really rigorous kind of baseline. And then we followed them for 2 years post-intervention enrollment. So it was over a very long period of time, longitudinal analysis and a trend analysis. We were looking at proportion of time points with undetectable viral loads. And we threw in all the correlates that we knew were probably associated from previous research, all demographic variables, baseline adherence, substance use, mental illness, physical illness, housing, which was extremely important, and socioeconomic status. We also conducted qualitative interviews with 50 participants, and I'm happy to talk a little bit about that, but I'm not going to present on that because of the time point, but I'll expand on that in the question answer if necessary. So we published the research. A big shout out to Dr. Robert Ghose, who is probably on this call still, hopefully. He was part of this research and guided a lot of our design and interpretation of results. As you can expect, this was a highly socially compromised community we were working with. high levels of substance use, high levels of alcohol use, high levels of mental illness and homelessness. Almost 90% of folks were homeless. And these are the results. I'm going to just spell out why we did two outcomes. We looked at viral load below 200 as basically the state standard for being undetectable. We also looked at viral load below 50 because we got a lot of feedback from doctors that this was really the level where any kind of impairment went away, impairment writ large. So we decided to do a very rigorous, even more rigorous kind of checkpoint for detectability. And we found that pre-enrollment, the proportion of time points that the sample was undetectable at was at around 58%. And post-enrollment, as soon as they enrolled, immediately after, that went up to 75%. If you're looking at VL less than 50 copies per milliliter, if you're looking at less than 200, then that went up from 67 to 82.4%. And then we also looked at proportion of the sample who were undetectable at all time points. And at baseline enrollment for less than 200, that was around 39%, a very low percent, which went up very significantly to about 62%. We conducted logistical regression models on being undetectable at baseline, and we found that African Americans were almost twice as likely to be detectable at baseline, or half as likely to be undetectable at baseline. And immediately after enrollment, they went up. That significant effect disappeared. So they were doing well. In other words, they were no more vulnerable than anyone else after enrollment. At the end of the intervention, that's 2 years post-enrollment, right? At the end of the actual intervention, that continued to be the case. If we look at the more kind of stringent cutoff, we found that, in fact, African Americans were doing even better than everybody else at enrollment. They were almost more than twice as likely to be undetectable after enrollment. And after the intervention was over, they were also almost twice as likely to be undetectable. This was true for folks who were homeless. They were almost half as likely to be undetectable at baseline, and then that association went away as we moved forward. The same was true of substance use. I'm going to take a quick look at my time and make sure that I'm okay. It's time. I want to stop there. That's basically the.
Thank you, Dr. Ghose. That was such a really cool talk. We do have a couple questions. Nikita Wilson asked, or said, I love the graphics involved in advertising the program. How did the participants feel about the name of the project? Did you get any backlash with the name Undetectable Project?
Yeah, actually it was really interesting. We've focus grouped this a lot, and our qualitative data show that actually the incentives remove the stigma from undetectable or detectability. It became a process, a fight almost. We are in this process together. It wasn't really reaching undetectability that was really glamorized. What was glamorized was being part of the fight, being part of the superhero process. So we didn't actually get any pushback on that, in terms of, undetectability becomes this glamorized, valorized endpoint and stigmatizes not being undetectable.
And then Dr. Blank asked, or said, hi, TJ, I can understand why randomization was impossible as it is in many clinical settings. Did you consider a stepped wedge design or a regression discontinuity approach?
Yes, indeed. Thanks, Michael, for that great question. In fact, we are moving forward with a possible implementation NIH grant where we're thinking exactly along those lines. And also a comparison group. That last chart I couldn't present because of time was really comparing it to a group of folks who were not part of the VLS intervention, but were getting care from other kinds of interventions in other settings. So standard of care, so to speak. And we saw major effects there too. And we are trying to design this as a clinical study moving forward.
And Dr. Ghosh, if you'll entertain me, I do have one question of my own. So when you were talking about who you were including in your study, you were mentioning somewhat of a wide net in terms of hard to reach populations, such as the LGBT community, homeless, people with mental health concerns. How did you consider different parts of your intervention in terms of how you needed to adapt to specific communities or at the intersections of different communities?
Yeah, this is a great question. We really paid very special attention. Housing Works is an amazing agency that has lots of these connections in the community in New York. It runs a boutique, well-known clothing store, for example, that actually employs many folks across the communities. We also paid very close attention to the implementation scientists. And I know this is going to make us a little bit uncomfortable, but we almost always see in implementation science where a team of implementers is people of color and part of the community, but a team of scientists is always, very white and from academic institutions. We really went to great lengths to make sure that the teams were very coordinated and were diverse. And the front face of the team was the back face of the team too. In other words, we were part of a collaborative, diverse team. So when we went out, we could secure buy-in. We didn't secure buy-in for some folks, but we did, I think, secure buy-in for a lot of folks who wanted to be part of the study and the intervention.
Great. Well, thank you so much for that amazing talk. I really enjoyed it.
Thank you.
Okay, so I am going to move on to our next speaker. I have the pleasure of introducing Professor Omar Martinez. Omar is an associate professor at Temple University's School of Social Work. He plays a critical role in the development, implementation, operations, and leadership of Temple University's Implementation Sciences Lab as director and founder. His research integrates perspectives from public health, medicine, law, social work, and human sexuality to create interdisciplinary strategies that address health disparities and inequities among key populations, including sexual and gender minorities and Latinx communities. So Omar, the floor is yours.
Excellent. Thank you for that introduction. The title of my talk today is Implementation Science to Optimize the Use of Evidence-Based Interventions in HIV Prevention and Care Among Sexual and Gender Minorities, Latinos, Latinas, Latinxs. I'm going to try to get this outline in 10 minutes, so just bear with me. The first, I want to talk about our work on syndemics, immigration, and stigma as drivers of HIV among sexual and gender minorities. Then I'm going to tap into 3 unique projects happening here in Philadelphia. We're wrapping it up. The first one is Connecting Latinos en Pareja, a couples-based intervention for Latino male couples. I know Brian Hernandez is logged on and he was part of this project, so big shout out to Brian. The second one is Medical Legal Partnership, and the third one is a trans equity research project led by Tatiana Woodard here in Philadelphia. I'm going to wrap it up with future direction and a discussion point. First on syndemics, and I want to bring in some data to kind of understand why disparities in HIV. This was a study that we conducted in New York City with behaviorally bisexual Latino men. Over 1/3 reported polydrug use. 22% of the sample reported childhood sexual abuse. Over half of the sample reported high stress. When we took this to the syndemic models, syndemic conditions were associated with STI diagnosis and condomless anal intercourse. We also continue this work on syndemic here in Philadelphia. Big shout out to Coleman and Kathleen Brady for enabling, for sharing this data. It reminds me of for us, by us, right? Leading this research for our communities. Once again, the sample of Latino men who had sex with men reported high prevalence estimates of heavy drinking, sex work, and homophobic discrimination. When we build this into the syndemic models, participants with 2 or more factors reported more male partners and more condomless anal intercourse with their casual partners. Building from this, a lot of our work is looking at immigration, right? And in particular, immigration as a determinant of HIV prevention and care. Our research has documented the detrimental impact of intertwined process of immigration, of health and wellness. In particular, for sexual and gender minority immigrants, anti-immigration rhetoric is often linked to HIV acquisition, transmission, and delays in care. As a behavioral researcher, I always bring the voices and experience of our community members, and here is one of those voices. Many people won't go and seek out services because they're afraid it will affect their immigration status. For fear of being found out as undocumented immigrants, they don't go and seek out help. We just published another paper here looking at stigma, right? And looking at the stigma as a determinant of HIV prevention and care among sexual and gender minorities individuals. And unique of this paper is that at the end, I highlight, right, some of these interventions that have proven to be efficacious when working with sexual and gender minority Latinos, including the work of Scott Rhodes, Sonia Riola in California, and so forth. What are we doing here in Philly? I received 4 years ago a U01 grant from the CDC to test the preliminary efficacy of a couples-based intervention for Latino male couples. One key of this project, one key element of this project, that it was driven by a community advisory board. Community members led all the stages of the research projects. And it's evident, right, even in our recruitment materials. And I'm just going to highlight this story really quick here, right? You see these recruitment materials. I was coming from New York City from my postdoc, and the first thing that came to my mind, sex sells, right? We need to build recruitment flyers and materials with hot, shirtless Latino men. And that cab actually stopped me and said, let's actually step back and let's fight the hypersexualization of Black and brown bodies in HIV prevention research. So it was a very humbling experience, a very practical experience, and once again, adds value to the importance of community advisory boards in all the stages of the research process. Here's a snapshot of this intervention. It's a 4-session risk reduction intervention. One session, session 1, goes over personal, cultural, and contextual influence of risk. Session 2 addresses issues of communication and the prevention toolkit. Session 3 talks about relationship building and strengthening, and session 4 on social support. Here is a snapshot of our manual. One key component of this intervention is that when we presented the prevention toolkit, right, condom, preps, treatment as prevention, we presented it under the hot, fun, and safe sex, right? Kind of moving away from that risk framework. And you can have hot, you can have fun sex with your couple if you use one of these prevention toolkits. Case scenarios and case studies that we build in, that we develop responsive of the experience of Latino male couples. That was really essential. And dissemination. This is a revise and resubmit paper. I have I believe 10 co-authors that are community members, right? So community members and our community advisory board helped write this manuscript and disseminate it. One of the key highlights of this manuscripts, right, I want to highlight one of the themes: use gain frames rather than loss frame, reducing risk. That was another key takeaway. So from that engagement of our community advisory board, moving away from this risk framework and focusing on the gains frame. And I'm glad that Sarah Bass is here, our communication expert, to demonstrate the importance of this. Wrap up, these are some of the voices of the couples that have been engaged in the couple study. I'm going to highlight just one of them. Connecting Latinos en Pareja has been an eye-opener for not only sex and health education, but for the many ways we can grow as a whole in community or relationship. Second, baby, medical legal partnerships. This work started when I was in grad school doing the JD and PH program. Medical legal partnerships offer structural integrated intervention that could facilitate improvement in medical and psychosocial outcomes among people living with HIV. We received an R01 to actually, NIH funded R01 2 years ago. We are now in the no-cost extension year to package an intervention to improve outcomes in the HIV care continuum for people living with HIV. Snapshot, the added value of the training in the healthcare teams address health harming legal needs, prevent issues from becoming legal needs, training to the staff. I have heard throughout this presentation the importance of training to the healthcare staff. Here is kind of one of the end products of our work. We engage over 100 providers engaged in medical legal partnership and 50 people living with HIV. And what we found within these healthcare centers, 3 continuums of care, right? The HIV care continuum, the legal continuum of care, and the social service continuum of care. We took this to NIH. We received a good impact score. We barely made it. We couldn't make it this round, and we're resubmitting this proposal to test the feasibility and acceptability of the package that was developed as a result of the R1. Moving this line of work forward, here is we applied, not as successful, to an NIH grant to test this medical legal partnership model to address disparities and inequities with COVID-19. It was driven by CFAR and REAIM, Implementation Science Framework. We're repackaging these, hopefully, to a foundation grant. Last but not least is the Trans Equity Research Project. Once again, big shout out to the Department of Health, Coleman, who has supported this particular project. We engaged a community advisory board to develop an intervention for men and women of trans experience. 20 members guided this research project. Tatiana Wooder, the project director, led this project. We also engaged a scientific advisory board. We also conducted in-depth interviews with community members and peer navigators. We screened over 40 individuals of trans experience here in Philadelphia. Snapshot of the demographics, a diverse sample in terms of race. And one thing that I want to highlight here, in addition to HIV, we ask about other comorbidities. You see a high number of participants reported asthma, diabetes, high blood pressure. We also ask about discrimination, right? Once again, discrimination as a determinant of health. A high number of participants reported discrimination. 4 out of the 40 tested positive for STI. So we had a high number of participants who reported STI, and we can have a follow-up discussion on missed opportunities and way to move forward on this particular topic. Snapshot of the end product, a 3-group level intervention, self-care, communication, and life skills. I hear throughout this presentation the importance of housing, job development, resume building, that emerged as well. 3 takeaways. Syndemics matter, right? Our communities are disproportionately impacted by syndemic conditions. So let's keep the conversation on this important framework. Let's improve our surveillance systems, right? Capture these social and structural drivers of HIV in our city. Let's be keeping our focus and consider immigration as a determinant of HIV prevention and care. Continue the investment in the development and implementation of locally developed homegrown prevention and treatment programs, Colors, Galay, Mazzoni. So let's continue that funding and that investment. And on implementation science, let's conduct more effectiveness research. I've seen some work on, great work on economic evaluation of these strategies and harnessing implementation science to promote health equity, right? To address these structural drivers of HIV. Acknowledgement, my mentors, my collaborators, our community advisory board, students, community partners, and thank you for your time. I think I made it.
Thank you for that amazing talk, Omar. I'm a huge proponent of syndemics research, so that was really exciting for me. So we do have a couple questions for you. Michael Blank said, "Hi, Omar. I wonder if you could comment about the implications for a syndemic approach for HIV in the Latinx population and what that has for COVID-19 prevention and treatment."
That's an excellent question, and I scanned through it really quick through this data, and based on the NHPS data set and the article, I provided that citation to the article is published. highlight a high prevalence estimate of these endemic conditions. Discrimination, homophobic discrimination, more than half of the sample reported that. Housing instability, food insecurity. So that's an excellent point. And every time my work on syndemics is moving away from these behavioral syndemic factors and integrating these social and structural syndemic conditions that I will argue are the drivers of the HIV epidemic among the communities, right, that we work with, right? In particular, I mean, it was mentioned earlier, discrimination and providers interaction, stigma. These papers, I mean, the data, the qualitative data that emerged from the focus groups with men and women of trans experience, that out of the 40, none have ever tested positive for rectal STIs, right? So in my mind, it was a limited $20,000 project. It's like, why that? Why providers are not offering rectal STI testing for these men and women of trans experience? So I'm thinking about all these syndemics factors, stigma, prejudice, right, discrimination, that perhaps are the determinants of this high STI prevalence among this population. So thinking on syndemics, and I'm glad that Anna is here and expand this work, I think that we need to be focusing more on these social and structural drivers and less on put on a condom, right? Increase your communication, right? You got my point.
And Renad Betas asked, thanks for sharing that great example of how important it is to listen to our CAB and community members. What advice do you have for faculty on how to approach their work with the same humility approach and to not assume that they or that we know best? How did you learn how to do this?
That's an excellent question, and I'm not the expert here. We have other great experts, but the unique example of that trans equity research project, $20,000 small pilot study. I actually engaged leaders of our communities. Deja, Lynn Alvarez, being shout out to Deja, to Tatiana Wooder, before I actually applied to this $20,000 grant. So I had those conversations with community members to assess what matters, right? Is HIV what really matter when you're getting beat up on the street or you don't have housing, right? So it's doing that assessment prior to even developing our research question or putting together our research question. I think that has been one of the key, successes, I will say, of this particular project and to a lot of my projects, right? That engagement of those community members and have them on the table early on in the research process, not just when you get the multi-million-dollar grant. Hi, by the way, now we want you, right? Now we want to engage you. We're going to pay you $50 an hour to join this CAB for an hour, and that's about it, right? I think that has been one of the key takeaway lessons of my research, right? Early on engagement and pay for that engagement, right? I always build in one line item to support those processes in my budget. But excellent question, Renat.
Thanks so much, Omar. Again, that was a really amazing talk. So we're going to go ahead and move on to our last speaker. We have Omar Martinez Donate. Dr. Martinez Donate is a professor of community health and prevention at Drexel University Dornsife School of Public Health. Her program of research examines levels of HIV infection, factors associated with HIV risk, and development and evaluation of HIV prevention interventions for Latino communities in the U.S. and the U.S.-Mexico border region. She has been continuously funded by the National Institutes of Health since 2007. So the floor is yours, Dr. Martinez Donate.
Thank you, Stephen. Let me try to share my screen here. So it's a pleasure to be here and share this time with all of you, and I'm really so impressed with all of the previous talks. And in particular, this last talk by Omar, I think, has set a perfect foundation for what I am here to present today. And this is the results of a pilot intervention that we have tested here, in fact, in collaboration with colleagues like Omar and others from Drexel University, as well as some community partners from the Philadelphia AIDS Consortium and Women Organized Against Rape. So as Omar was saying, basically, we had to look at this from a syndemic perspective. And I, talking about community advisory boards and humility, when I first arrived in Philadelphia, I knocked on probably every door in terms of organizations that provide care and services for the Latino communities here in Philly. And I presented myself as an HIV prevention researcher, and I was interested in working with them to develop HIV prevention programs. And what I heard very immediately after, I communicated this intention, this desire to them was, sure, we are very worried about HIV, but we are also very concerned about the role of mental health. We are also very worried about excessive drinking among our community. And we are also very concerned about the role of domestic violence. So we cannot just work on HIV prevention. All of these other issues are really so interconnected. And I knew that, right, as a researcher, but I wasn't really acting on that. So this program represented an effort to really integrate these often separate epidemics that are really connected from a syndemic perspective. So just a few highlights on why we focus on Latinos specifically. They represent about 20% of new cases of HIV, and they are experiencing persistent disparities when it comes to the continuum of care, in part driven by higher rates of other sexually transmitted infections. And we have to be mindful that migration, 1 in 3 Latinos here in the US is a foreign-born individual. And we know that migration is a social determinant of health and is related to increased risk for acquiring HIV infection, and also related to barriers to access services like testing and treatment. These disparities on HIV, as I said, are occurring concurrently with disparities in mental health. About 40% Latinos will experience a mental health disorder in their lifetime. And we know that with length of residence, Latino immigrants increase the risk of experiencing mental health issues. We know also that there are important disparities in accessing mental health services for Latino communities. And substance abuse, in particular alcohol consumption, Omar was referring to that for MSM Latino men, is also an issue that we need to be mindful of regarding the role that it plays for increasing the risk for HIV infection for Latinos. Finally, violence, and in particular violence victimization, is also experienced at higher levels among Latinos compared to non-Hispanic whites. And we know that there are multiple legal, cultural, familial barriers that prevent Latino and Latina and Latinx populations from reporting experiences of violence and from breaking the violence cycle. So what is this syndemic orientation that we're talking about? It's really this idea that these health issues or challenges are clustering, they're interacting with each other and are influenced and driven by social, political, and economic inequity. These syndemics have been documented among different populations, including Latinos, and I'm glad Omar went before me because he's one of the leading researchers when it comes to syndemics and Latino communities. So our program focuses on what we call the SABAME syndemic. SABAME because it stands for substance abuse, HIV/AIDS, violence, and poor mental health. And as you can see from this socioecological analysis, there are multiple factors at the individual, all the way through the broader structures that are at the basis of the disparities that we see across these 4 syndemic health issues, including, and not excluding other things, but including stigma, immigration status, and the structure of our health system. So I'm going to skip a little bit this to give more time for questions, but I just wanted to, I guess, point out the known, well-established connections between HIV and substance abuse. We also know that mental health contributes to HIV transmission in Latinos, and problems like depression hinder retention into HIV care. Here in Philadelphia, an estimated 43% of people living with HIV has a mental health diagnosis. And as it was pointed before in the chat and in the Q&A section of the previous sessions, why are not we screening everybody for HIV in mental health settings, and vice versa? Why aren't we screening more for mental health when it comes to people who are at risk for HIV? And finally, HIV and violence victimization, clear connections between these two health and behavioral and social issues. So Latinos in Philly, for those who might not be so familiar, are about 15% of the total population, and is a very diverse community, or I should say different communities within this larger community. About 61% are from Puerto Rico, and 1 in 4 Latinos here in Philly are foreign-born. They have tremendous social determinants of health that really hinder their ability to achieve excellent health, their potential to thrive. They have the highest poverty rates, the highest unemployment rates. They live in the most disadvantaged neighborhoods here in the city, and they are more likely to report poor and fair health. They are the community with the highest uninsurance rates, and they also have low social capital levels. So all of these stacks against them to be able to stay safe from HIV, from violence, from mental health, and from this overall syndemic. There are health disparities among Latinos in Philly across these syndemic factors. I don't want to spend much time going over, but let's just say that after African Americans, Latinos are the community that has the second highest rates of these factors. So here comes our project. We call it CRISOL. And the rationale is that we need integrated interventions that simultaneously address these syndemic conditions, and especially the underlying causes, including access to services, which is a hinder for many of the socio-ecological determinants that we mentioned earlier. To our knowledge, we didn't see evidence of any known interventions that simultaneously address the SABAME syndemic in Latinos. And we wanted to build this on some evidence-based and promising intervention approaches, such as peer-driven interventions and community resilience. The POL model is well known in HIV prevention, is an evidence-based model that, to our knowledge, have not been applied to the SABAME syndemic. And the idea here, for those who might not be so familiar, is recruiting and training influential community leaders to adopt new behavioral norms and to disseminate those healthier norms within their social network. It's based on the diffusion of innovation theory. And community resilience is a strength-based approach that seeks to enable individuals and communities to build on and overcome adversity and trauma. It's an empowering approach that is particularly indicated for disadvantaged and underrepresented community members. One important element in community resilience interventions is the establishment of formal and informal ties between people and resources. And so we thought that this community resilience approach had important but untapped synergies with traditional peer-driven approaches. So the CRISOL program is a community-based participatory research that we did in collaboration with providers of services for Latino communities here in Philadelphia. And the goal for our program was to really develop it, implement it, and evaluate it from an implementation perspective that is with emphasis on feasibility and acceptability in the process, as well as trying to obtain some pilot efficacy data. So it has some hybrid effectiveness implementation elements. And this is part of a larger research program where we're trying to understand more thoroughly the SABAME syndemic among Latino immigrants in Philadelphia. The program consists of an initial phase where we trained, the goal was 8 to 10 community leaders, and the program consists of 40 hours organized in 10 sessions. and is delivered in Spanish. And then following that training, there is a community outreach phase that has lasted for 9 months. And during that phase, the trained leaders have been reaching out to their networks and operating as influencers, as health promotion agents. And we as facilitators have been supporting them through sessions every other week where we provide support and help with the special topics. The module, the structure of the training, you can see a little bit of the flavor here. The objectives are for the leaders to acquire knowledge and skills to educate and inform others in their networks, to model healthy norms, to link others to services, and to build self and community resilience. We also were very intentional in trying to build links between these leaders and professionals, providers, and organizations in the community. We used a variety of evaluation, data collection methods, some of them very traditional. I want to point out that our evaluation was guided by the RE-AIM framework, which is an implementation framework that, in our case, emphasized reach, adoption, and implementation. And I must note, too, that during the outreach phase, leaders were given iPads with Qualtrics forms that they would use to document their contacts, their interactions with other community members, and the type of service, the assistance that they provided to these community members for evaluation purposes. So in terms of the reach and the adoption, we heard from 33 community members that were interested in being trained as leaders, and after some selection process, we enrolled 15 of them in the program. 13 finished the 40-hour training, and they were, as you can see, from a variety of regions within the American continent. 9 of these leaders went on and continued operating during the outreach phase. And all of these 9 individuals are still active and enrolled in the program with us. Attendance was really high. Out of 10 sessions, the mean attendance was 9.7, training fidelity 76%, and satisfaction also very high, 3.9 out of 4. The leaders increased significantly their level of knowledge and behavioral skills. We did see an increase in resilience, although that didn't reach statistical significance. And in terms of the reach in the community, they recorded a total of 824 interactions with other community members throughout the 9-month period, which was about the goal that we had established, which was 10 contacts per month per leader. Of those contacts, about half were unique interactions, and the other half, a little less, 47%, were repeated interactions with community members. And of course, we were affected by the COVID-19 pandemic. This hit Philadelphia pretty much around 2.5 months into the outreach phase. And it had some impact on the type of services, the type of assistance that the leaders provided to others in the community. You can see here a snapshot of the topics that the leaders discussed with community contacts. About 32% of the discussions focused on SABAME factors properly, HIV, mental health, substance use, and violence. But as you can see, 22% of these conversations were about COVID-19, because this is what was happening for much of the outreach period. And as you can see, other social determinants of health, such as food challenges, employment losses, legal difficulties, and resilience, and the need for resilience during this pandemic. In terms of help offered to community members during these interactions, the main types of support that they provided was in the way of counseling, followed by referrals, and a third of these referrals were specifically to services directly related to the SABAME syndemic, that is substance use services or violence prevention services. 20% was education and information and provision of knowledge. And of course, this distribution changed from before to after the pandemic, with a lot more emphasis on COVID-19 and social and related challenges after the pandemic hit. An analysis of the contacts indicates that they were 64% females with a mean age of 38%, mostly heterosexual. The vast majority were foreign-born, and 40% were from Mexico and 25% from Central America. The mean satisfaction of these contacts with the interaction that they had with the leader was 4.4 on a scale from 1 to 5, so pretty high. And for the most part, these contacts were acquaintances and friends. This reminds me a little bit of the importance of the weak ties, the people who are in these extended networks that benefit from the knowledge and the connections that the leaders acquire through this training. As for where the contacts lived, mostly South Philly, as well as other areas like North and West Philadelphia. We did collect a little bit of efficacy data with behavioral intentions after the interaction. The contacts reported in about 36% of the cases that they were going to use strategies to reduce COVID risk or seek COVID testing in about 15% of the cases. And then you can see other important categories of behavioral intentions were reducing unprotected sex, seeking HIV testing, and reducing stress, alcohol, making a safety plan to prevent violence. In conclusion, we think that pilot intervention was feasible. I'm sorry, am I out of time?
I was going to say you have about 60 seconds.
Okay, well, we think this bodes well for a future effectiveness, hybrid effectiveness implementation community trial that we are hoping to implement in the future. And we believe that this type of program is showing high levels of adoption, high reach within the Latino immigrant community. We think it's a broader syndemic approach that is important to complement other HIV prevention, more traditional, more narrowly focused, that might work for other populations, but certainly is insufficient for Latino immigrant communities. So these are our next steps, and happy to take questions. Thank you very much.
Thank you so much, Anna. That was a fantastic talk. And I, for one, am really appreciative of those who really incorporate this, resiliency perspective. And I think it speaks to a lot of what people have been talking about through this talk, that, that people aren't broken, the systems are, and that, people are strong, they're resilient. And it's about, developing sort of an infrastructure that meets that resilience and strength. I think that we might have time for just one question if anyone has any. I'm not seeing any on the chat. So I guess maybe I'll ask, so the part of your, I think conceptualization of resilience has focused a lot on linking people to formal and informal contacts. I was wondering if you could speak a little bit more about what that looks like, and maybe other areas of incorporating resilience into intervention work.
Sure, that's a question. We felt the need to really help assist the community with accessing services, with starting with increasing awareness about the services that are available, which is a big issue sometimes for newly foreign-born individuals who are not familiar with the system, are not familiar with the city, and they don't know where to go or what's out there that can help them with these different needs. So one of the ways in which we try to address this was by educating the leaders for them to become more knowledgeable about what are those services that exist and how one can access them. And one particular way in which we did this was we invited a panel of representatives from Latino serving organizations here in Philadelphia. And these providers came to the training, they introduced themselves, they talked about their organization and the type of services that they offer. We had people from Congreso, for example, talking about their HIV clinic. We had people from Hispanic behavioral services talking about the mental health services that they offer to Latino communities. And we had people from Hayes, Pennsylvania, talking about legal services. And they were able to put a name of an organization with a face, with information about the type of services that can be accessed there. And that way they were empowered and more and better able to transmit this information to others in the community.
Great, thank you. And I just have one last question from Dacry, who asked, was there any reluctance to working with your projects?
What do you mean in terms of the leaders, or what? I'm not understanding the question well.
There's a great presentation. I wanted to say that your engagement in the community is a plus. Was there any reluctance working with your projects, maybe on the community engagement side?
I don't think we faced any reluctance. We had really good response to our advertisement of the opportunity for training. And subsequently, after training this first cohort, we have heard from additional community members, are you guys offering this training again? Because they, many see it as an opportunity to grow professionally, to perhaps start or continue a path that they couldn't walk before due to many barriers, and language being one of them. There are very few programs that offer this type of opportunity to non-English speakers, and many of our leaders were monolingual Spanish speaking.
Thank you so much, Dr. Martinez Donate. I am going to now hand over the reins to Florence, and we will move on to our next section.
Thank you so much, Stephen, and thanks to all the speakers for this amazing job. So now we're gonna end this session by just going through a series of discussion. So please, as you think of questions, or even if it's just general reflections, include them either in the chat or the Q&A. It's actually my pleasure to introduce one of our infectious disease fellows. One of the goals of the CFAR, and particularly our SWIG, is to sort of highlight young and upcoming scientists interested in HIV, and Bugatti is one of them. Bugatti Loabile is a second-year infectious disease fellow here at Penn, and she is doing her master's in epidemiology. And she's going to lead us into general sort of reflections and discussion.
Thank you, Florence, for that introduction. I'd like to thank all the presenters today who shared their interesting work and their expertise. I think it's definitely been inspirational, especially for me, and I definitely feel the passion that everybody has for the concept of healthcare being a basic human right for everybody. I'm originally from a country called Botswana in Southern Africa that, as a lot of people know, has been hard hit by the pandemic. And we've used community healthcare workers to manage infections such as TB, and that's really been successful. So I think the developing world has definitely shown us that community health workers work. And I think it's very difficult to make a comparison to the United States. Coming here and learning about the healthcare structure here has been definitely very dizzying, and it's difficult to make those comparisons. I think what really strikes me from the talks today, that to get all this important implementation research to become more widely available for our patients, is going to need a lot of buy-in from every single level, from the person who answers the phones in the clinic to the highest levels of government that's providing the funding. And it makes it even more complicated in the United States because of how complex and political the healthcare system is, and how differently it functions state by state. So I have a question for any of the panelists who have any thoughts about this. What do you think are some of the barriers to getting more buy-in from, the insurance companies, local leaders, politicians, and the government? Because these are very important out-of-the-box strategies for these hard-to-reach marginalized populations. And especially because it's going to be dealing with more than just actual healthcare setting needs, but the need to address significant social economic disparities. Does anybody have any thoughts about barriers they've encountered or barriers that they believe are there?
And if I'm going to sort of call people out, particularly starting with people from the health department. So Coleman or Kathleen or Javante, if you want to start with that question first, that would be great.
Javante, you're muted.
Yes, you're muted. You need to unmute yourself. Go ahead. I think you're unmuted now. Oh no, I can't. We can't hear you.
No. Do you want to put your earbuds back in? I think that was working earlier. Oh, here's Coleman.
Well, I think what we have at the health department, we have a lot of barriers of data and that we've looked at and categorized from people. I mean, there are people who have been disengaged from care and brought back into care, and I showed some of those sort of provider level barriers. What we've have categorized, there are sort of things cross over. There are barriers that relate to providers, and that also could be socioeconomic barriers and barriers about patients' rights and education, and so that we sort of look at all of these things, and we're very focused on those things that we in the HIV system can address, and looking at how we can leverage other systems to the extent that we can. I don't have all of the lists down in front of me, but I think that is one of the key things. I mean, the biggest thing, though, I think that we have to really think about in terms of some of these socioeconomic barriers is housing in Philadelphia is it's not available. We don't have, with our Ryan White money, much to be able to do for a long-term solution for that. And so I think that's a pretty critical area. Do you have anything else, Javante or Kathleen?
I don't.
If I may jump in, can you hear me?
Yes.
Yes.
If I may jump in, this is Toorjo Ghose. I think we haven't really talked about incarceration in Philadelphia. It really is intersecting with everything. One in almost every three, African Americans and Latinos in Philadelphia will have some kind of an incarceration record by the time they're 45, and that's just incredible. We're, on probation and parole. You can't expect to be in treatment when there are such stringent requirements to, for everything around your daily living. So that's a huge, and it's not even incarceration as much as it's surveillance in the community. So it's a huge barrier. And, being on probation and parole is itself one of the highest risk factors for health. The other thing is, we have some pretty, and I'm sorry to bring this up, but, me, I'm going to be impertinent. But, we have crazy policies like the smoking ban in treatment centers in Philadelphia. That comes from the Department of Health. That, for any scientist, any harm reductionist, that just does not compute. Most of my guys will drop out of care if they can't smoke. And I'd rather they not inject than not smoke. So this harm reduction mentality, it's in housing too. We do not have a real housing first mentality in Philadelphia. The way it's implemented, it's always connected to some kind of mandatory treatment and care, even when we stipulate that it's housing first. So there are many, many, many barriers in Philadelphia that is about ideology and about non-evidence-based practices. Sorry, just putting that out there as some of the barriers.
That's a great thought, and it's also, thinking about basically, how policies are made, and based on, philosophy, and unfortunately, it doesn't necessarily put unity at the center, and that's a very great point. particularly with Anna and Omar, since you have your eye on syndemics, I just wanted to see if you have any particular comments. Sometimes it's really hard to not be overwhelmed by all the structural barriers. So in your work, how do you think you can approach to solution building in a way that is consistent and sustainable, and can help sort of move the needle in the right direction?
I know that sometimes it really feels unsurmountable. It's a lot to take in at once. But I think that really is this emphasis of some of these social determinants and to see them as intricately related to health and the health outcomes that sometimes are the basis for funding decisions. I think to take a step back and adopting for real, these social determinants of health, to understand, for example, that immigration laws are health laws, to understand that laws in violence and violence victimization are health impacting health directly. I think that would is something that we need to be moving more. Omar is working with these medical legal partnerships, and I think that's an excellent model of how we had to really think outside the box and address those social determinants. We talk about them, but it's hard to intervene on them. And the incentives are not there, and evaluation of these type of interventions is also really hard. You can't go to your typical randomization model, and we know that sometimes that is also against us when we try to get funding to really implement this kind of program. So I don't know. That's my 2 cents on this. It's a difficult question, Florence.
No, that's an excellent question, and thank you, Anna, for bringing that up, right? And it's evident, right? Like, so here is a medical legal partnership structural approach, right? And we struggled to get it funded, right? Even from the gatekeepers, right? So we got a score for the one with folks living with HIV, and we have to resubmit. But even the challenges, right, of getting this structural approaches funded, right? Because Anna just mentioned some of the limitations on the design, right? The COVID-19 medical legal partnership didn't even get discussed, right? So is that a struggle selling that to funders, right? And linking that structural legal aid to viral suppression, to improvement in the COVID-19 response. So those are some of the challenges, but I'm a strong believer of medical legal partnerships and addressing some of these health harming legal needs impacting our clients and our patients. Another big shout out, so North Carolina just have this Medicaid expansion model to cover for this social and structural determinants of health. So from a macro standpoint, let's be thinking about these models. It started last year and is being evaluated. For example, legal aid will be covered through this Medicaid expansion model. So it's thinking about innovative ways to fund and sustain these structural approaches, right? So that's my 2 cents.
Can you hear me? Can you hear me now?
Yes.
Yes.
Yeah.
I'm home because it's like biting at the bit because everyone is saying what I was going to say, but I tried to chime in first. I think it's the policy. Where we are now in the epidemic, we have to approach policy, right? And someone made the reference about smoking bans in treatment centers. Another person made a reference about texting, right? And we know that if you start texting and you have those types of interventions, then we run up against HIPAA regulation and people having concerns about privacy. And so my background in nursing, we use the teams approach, the interdisciplinary teams. The nurse doesn't dictate the nutrition protocol for the patient. The nurse doesn't dictate the pharmacy protocol for the patient. It's a team approach. And so we need to move away in implementation science from the one person having the answer to a teams approach. The health department needs to consider the work that Omar is doing in terms of the legal policy and connect that with the policy of treatment, right? And so I think that once we start to build these coalitions, and on my slide, I had that as the first stepping stone to making radical change in our implementation science. If we build community coalitions, someone else on the team is going to have the answer for a piece of the puzzle that we need to work on. And then we go together to get funded, because it's not just people coming to ACO, it's ACO also saying, this is the data for Philadelphia to CDC and HRSA, and saying, this is what we need to be investing in. And I think that building those types of coalition to change the policy based on what research is showing is effective is going to be the most efficient tool we have in our toolkit. That's all I want to say. Now I'll go back on mute.
Thanks so much, Javante. And go ahead, Anna. Go ahead.
Piggybacking on Javante's point, I think that dialogue across different sectors, those coalitions or collectives, as you might want to call them, are so important. And I don't think we do enough of that work. I think we work too much in silos, and I know this is commonplace. We use this, but we actually don't move too much away from that model. And I just want to share very briefly that as a result of this, crazy pandemic we're going through, one of the things our team has been involved with is the development of this Latino Health Collective. And this is simply a monthly virtual gathering where representatives from Latino serving organizations throughout Philadelphia, but also researchers and city agencies like the Public Health Department are showing up once a month to talk to each other and tell everyone what we are up against, what they are seeing in their clients, what they are doing in their organization, what are challenges they're getting ready for, what are things they've learned that work for them. And we're having representatives from legal, behavioral, clinical, you name it, all kinds of sectors. I think we have to forget a little bit about the outcomes, whether it is HIV or HCV or you name it. You can put whatever the outcome out there. A lot of these integrative efforts are going to be beneficial for a variety of outcomes, and of course HIV being one of them. So I just want to put that out there. I think we need to do a little more of that and evaluate it too.
Hi guys, it's Nikita. I just want to mention to everyone's point also, like as being a community health worker, that I've noticed where inside your own, home of the clinic setting, like where you don't even have that intersectionality where social work talks to nurses talk to, like, it's just so diverse. So with me here in Baltimore, like what I would love to be able to create is that network of community health workers that I can call on someone up in, Philadelphia, like to really utilize this system and try to break this healthcare system the way it currently is. Cause it's just like, yeah, I'm working on what I can do for the patient, but like, it's that network that you could build amongst each other to be able to really help. Because it starts with us first. Like if we don't even know who each other are in the office, or how are we going to explain to our patients, like, this is your care team and these are the people that you can depend on. If I don't even know who, Stacy is up at the front counter, like we really need to talk to each other more within our clinic settings.
Great, thank you. And I'm going to turn it over to Stephen and Renad, since we just have a few more minutes before the end.
Yeah, so I'll kick us off and then pass the baton to Stephen. I just want to thank everyone for the amazing presentations and engagement and hanging with us till the end. I know the virtual format is different, but we're still able to come together, and that's so wonderful. Want to thank the CFAR and Pisceat LDI for co-sponsoring, Kate and Mandy and Carly for all the behind-the-scenes work that happened to make this possible, as well as our tech support. There's a fabulous person who's been supporting tech, and thank you for that. We hope that this series of talks and discussion has whetted your appetite to think about the intersection of implementation science and HIV care. This is just the start. So this is the official launch of our implementation science SWIG. We hope that everyone that's on this call joins us and becomes a part of that. I'm speaking on behalf of our leadership team, so Florence, Stephen, and myself. Just want to briefly kind of share our mission and what we have planned. So I hope that today is kind of a window into our mission, which is to draw on the deep expertise in implementation science and HIV care, here in Philadelphia, and bringing together PDPH and this greater Philadelphia community to support the development of community academic partnerships, to create capacity for collaboration. And so our goal is to work in service of our shared mission to end the HIV epidemic collaboratively and equitably. And we're really excited about that. So you will get an email asking you to join our SWIG shortly. This was our kickoff event. We'll be hoping to identify stakeholders across Philadelphia with expertise in HIV prevention and care, implementation science, and the community perspective. Try to identify opportunities for collaborations amongst these groups. And we also want to build capacity. So this scientific symposium is one way that we're doing so. We're also hoping to sponsor scholarships. We have a Penn Implementation Science Institute that we'd like to have folks attend. And also we want to do a community-facing implementation science training in the coming year. So we have lots of things planned, and we hope that we can partner collaboratively on this, and we're just really grateful for everyone's support. So I'll turn it over to Stephen to kind of close us out. I just want to share one point before I do so. I work in a lot of different contexts, and I just want to make an observation as an implementation scientist. I think that our city partners have so clearly laid out an agenda for us on how implementation science can help us answer actionable and impactful questions. This is a gift. It's not always the case that there's such a clear agenda and shared mission. And I really hope we can rise to the occasion and to collaboratively end the HIV epidemic. And so I'm just so grateful for that gift, and I hope we all rise to that occasion. Stephen?
Yeah, thanks, Renad. I just wanted to piggyback off of Renad and to all of our community members who are present and any connections that anyone has, please reach out to our SWIG for any feedback or for any suggestions as far as any way that we can be a useful resource to the Philadelphia area in the area of implementation science. You are all certainly, the heroes who are on the front lines of this epidemic. And, it's not that you're here for us, it's that we're here for you to support the work that you do and be a part of, this important change towards ending the HIV epidemic. I just want to close also the same thing as Renad, just thanking everyone who made this event possible. So the Penn Implementation Science Center, the Penn CFAR, the Philadelphia Department of Public Health, such huge support. Thank you to Dr. Cargill, Dr. Farley, Nikita Wilson for that amazing keynote speech. Your insight has already generated so much excitement and motivation from, researchers and community members in the Philadelphia area, and how we might take some of the ideas that have been successful with you guys and implementing it here in Philadelphia. Thank you to the panel speakers. We know that this was such short notice, but you all came through and were so informative, and we're super thankful for your wisdom and insight. And then lastly, thank you to the planning committee for helping create this in such short notice. So I am done. I think that that is all. So thank you everyone for attending.
Also would like to thank Hervat for her help with planning. I'm sorry I left her name out. That was not my intention. We're just so grateful to everyone. Thank you.
Thank you, everyone. And we're very excited about the follow-ups. And we are definitely looking to working with you. Like Stephen said, we're here to serve you, and to sort of piggyback on what Anna said. One of our goals is to really decrease the silos around HIV and community engagement throughout Philadelphia. And even though, we're all based at Penn, or this initiative is not a Penn initiative, it's a cross-city initiative under the EHE. And so we consider all of you our true partners, and look forward to further collaboration.
Thank you, everyone. It was a great opportunity, and I enjoyed sharing this time with you all. Take care. Stay safe.
Happy weekend.